and my boys, Roba, who grew up on Zoom this past year, and Hirko and Gonfa. They have been so patient with me as I was so busy in this work. And my husband, who stepped up to take care of them whenever he can. Thank you all for your support, and all my friends and all my families who have been there to support me. Thank you so much. I couldn't have done this without you. And my chair, Wendy, thank you for your continuous support. And you're like, you can do this, and you've been always there for me, always present through our weekly meetings. I really appreciate your support. And Christina, she's like, you can do this, Tigist, every time we meet on Zoom. And I complain, and she's there to listen. And it's just, you have so powerful words that kept me going. And you challenged me to do what I thought was hard. And I'm here today, so thank you. And Kristen too, when I started this project, my mind was like all over the place, and she kind of worked to like bring all the little pieces, keeping them on like one unique direction, and always sending some research, some topics, and she's like, this might be useful, you can do this. So thank you. I'm so grateful to all my classmates. We supported each other, and we complained, and we laughed. So I'm so happy. And lastly, but not the least, we all need someone, especially for me, who came to this country and who with experience of not being accepted with what I had previously. You just, it doesn't matter what you know or what you have, it just, you need someone, like the system is so complicated and not ready to accept people like me. And you need just some person who would be accepting you, giving you like just this little permission to try something and then kind of prove yourself. So I've had those people, just one people in Arizona, one people in Idaho, and one person somewhere. And these people just opened the door, and then it was easy for me to proceed. So Karen Hayes, who was the co-founder, and Jennifer Segedeli, she was the former program director, and they interviewed me when I tried to apply to this program like way earlier when it started, and then there were so many reasons that I couldn't join the program. And after interviewing me, they're like, here is the door, try. So thank you so much for accepting me. And like all the prerequisite courses were waived because they decided that it's okay. And I've taken these courses before, so they're like, you don't have to go through this. So these decisions, they really matter in someone's life. So thank you so much for believing in me. So why is this project? My original thought when I think about my independent project was to work on study traditional birth attendance in Ethiopia. And then it was a big project that it was hard to fit in this 1 year small program. And then I was struggling to kind of make the shortest direction. And then Kristen was like, why don't you just review what I've been already done? And then I went for it, and it was a good idea. And it was also very important. And And as I tried to think about it, then we had like so many strategies that were already implemented, but it's just like these quick fixes are not working. Like we send money to this one specific thing and it fails, or it's not changing anything. People are still suffering from the complications that these programs are trying to alleviate, but and nothing is working. So I tried to see what gap is there in these implementations, and also my own experience in Ethiopia. I've worked as a midwife, especially in the rural areas when I was a student. Through our apprenticeships, I've seen people struggling and this poor woman suffering from the complications of childbirth, pregnancy, and no one is helping them, and most of the time they experience disrespect. And the midwives also, I was one of the first graduates of the bachelor's degree midwifery program in Ethiopia, and I started teaching immediately after graduating, and I learned how to teach while teaching. So and the experiences of midwives in Ethiopia is the other thing which is so interesting. So my own experience also has its own place, and so the advocacy role comes with this. And also just I'm so interested in like finding the solution and bringing out like a change, trying to challenge the system so that the future midwives and the mothers who are experiencing these difficulties and the family suffering because of that could have like a better outcome through this. So introduction. So maternal, when we talk about maternal mortality is it's the days of a mother during pregnancy, birth, or postpartum, within the first 42 days of post-birth. And all mothers everyone has the right to have like access to just regular, proper health care. And for mothers, they have the right to have respectful and quality maternity care when they are pregnant, when they're giving birth, or postpartum. So when we are denying or when we are mistreating this woman coming to our care, then we are violating their rights, and families are not getting the care that's in their rights. And Ethiopia is one of the countries with the highest maternal mortality. And it's also discrimination against women, especially when we think about the disrespect and the abuse they are experiencing and the lack of quality care they receive. And maternal mortality is also evidence of a broken healthcare system, because so I talked about like the quick fixes that are being done for a very long time, but then we don't have like an integrated system that can connect like these quick fixes. And then so it's just a dismantled kind of implementation or strategy that had been done so far, and it's not bringing up any change. And there is a disparity in resource allocation between low and high income countries, and most of the strategies that are being implemented in Ethiopia and most of the low-income countries, they are donor-based and they are recommended by international organizations. So we don't have evidence for their implementation, and we don't also have like specific setting-based like recommendations. So it's always broken, and that comes with like the resource allocation. So it's not uniform, and even within the country, disparities happen. The rural community and women are living in the urban community are not properly cared for. So many of problems are also related to the availability of resource within the country and also in low income and high income countries. And the strategies are not directly studied, as I said before. And I have this interesting map of maternal mortality between, the first one is in 1995 and the second one is in 2009, the recent maternal mortality rate. And if you see, like, the yellow part is low income countries with the highest maternal mortality in 1995 are the same countries with the highest maternal mortality in 2019. Nothing is changing. And like, there very few countries they are out of this yellow color, but for the majority of the countries, they are still suffering with the highest maternal mortality, and we are doing something, we think, but nothing is changing. And this, again, countries with the yellow color account for more than 56% of maternal mortality worldwide. And like, when we talk about maternal mortality for the whole world, we're kind of talking about the low-income countries, because those are the ones contributing to this high maternal mortality. And when we come to Ethiopia, Ethiopia is one of the 5 countries accounting for more than 50% of the world's maternal mortality, and we have more than 15,000 women dying every year. And if you compare the lifetime risk of dying in Ethiopia compared to high-income countries, it's like 1 in 61, which is very, very high. And more than 50% of births is at home. And more than 80% of the population in Ethiopia lives in the rural communities. So the problem is very complicated. So when I did my literature review, so many problems I have identified, and it's just when we talked about this with Wendy, she reviewed the literature review and she's like, problem after problem after problem, and it's just like coming again and again with different but just continuous kind of stressful reading through it. And the summary is that the first thing I researched was just the trend of maternal mortality in Ethiopia. How is it's changing? And as I said earlier, with the map, it's not changing. Between 1990 and 2015, just countries throughout the world, they were trying to meet the Millennium Development Goal that was set to reduce maternal mortality by 2/3 for all the countries. And by 2015, none of, like, very few countries have made this, the goal, the 5th goal, which was talking about reducing maternal mortality by at least 70%. So when we think about Ethiopia, yes, there were like reductions in number, but the problem is still kind of stagnant, and it's there and it's not changing. And also thinking about how maternal mortality is registered in Ethiopia. Just if you go to different organizations reporting maternal mortality of different countries, you'll find different numbers. It's not consistent and it's not conclusive. So it's very hard to follow the track and to say, yes, maternal mortality has decreased or not, because there is so much inconsistency reported. And There is also an increasing obstetric violence with increasing facility births, and the recommendation that comes with decreasing maternal mortality is increasing antenatal care and skilled birth attendance, institutional delivery, and also increasing postpartum care. And in around 1990, the institutional delivery for Ethiopia was like around 10%. It was very low. And now we have around 49% of people giving birth in hospitals and health centers. But the problem is with increasing of these facility births, then we have increasing obstetric violence in hospitals and birth centers in generally in healthcare facilities, and women are experiencing disrespect and abuse. So that's like a shocking finding, especially for me. It was like so shocking because the reality, I have seen some disrespect in my own like experience, but then just finding that in number, and especially reviewing the qualitative studies that I have found through my literature review, and just listening, seeing what women were experiencing in their own words was so painful. So that was the other finding that I found in my literature review. And then for reducing maternal mortality, again, I will come to the results section, but there was training of like this community health workers, who were trained to reduce with the hopes of reduction of maternal mortality, and they were trained for like 1 year, and then they were attending births. They are not trained we can't say they are skilled birth attendants per WHO's definition, per ICM's definition. So we are letting these attendants to attend childbirth, and they are not skilled enough to prevent maternal deaths. They are not skilled enough to manage complications, and again, it's not useful strategy that was implemented. And digging deep into like the attendance of births at healthcare facilities, the biggest change that came with increasing skilled birth attendance was pushing the traditional birth attendants out of the system. So previously traditional birth attendants were attending like more than 90% of the births in Ethiopia. And then with the new push for increasing childbirth in healthcare facilities, then the strategy that was coming with it is pushing traditional birth attendants because they are not trained in modern way, and they are pushed from the system, and that had also its own impact on the quality of care women were getting, and especially with the modernization of childbirth and with kind of medicalizing births, which has its own complication. And then shortage of midwives and lack of coordinated referral, lack of resource, which is also a symbol of this broken healthcare system. And they called it like flooding strategy in Ethiopia when they were starting to find like strategies that would work. They said, we have shortage of healthcare professionals in general, so let's train more providers. So I was one of like that flooding strategy, and just increasing midwives, number of midwives, and increasing number of providers in the healthcare system in general. But then we were training like more providers who are not efficient in providing this quality care we are hoping for. So there is shortage of midwives, yes, but then the number of midwives or the quality of midwives that we were producing are not efficient. So some of the midwives are not different from like those community health workers who are attending births, because they are not given enough time to be competent midwives, to have the amount of resource also they need. And there is the referral system is broken. Like if you can do what you can and try to treat a woman properly, and then you refer her to a better like to a hospital, a referral hospital or somewhere, and then she will not get the type of care that she deserves, because somewhere there is no pitocin, or somewhere the resident who is supposed to do the C-section is not there, or the road is just not working. So is that rather than referring the woman, sometimes they just try to do their best where she is, because they don't have ambulances available. So it's just very complicated. And most available midwives are unhappy. As I said, like more than 40% of midwives interviewed in one research said they're not happy with the working environment, and they are unmotivated. Then they want to leave the work and they want to just do something else. And they also talked about how the midwifery training is not efficient, and how the curriculum of the midwifery program is not, it's not preparing them to be like competent midwives. And finally, I also found that there are no studies conducted to evaluate like these implementations over the long run. No studies were done to evaluate what was implemented so far. So, and before going to the next stage, I wanted to show you like how the healthcare system is structured in Ethiopia. So they call it like a 3-tier system. We have the specialized hospital serving like 3 to 5 million people, and we have the general hospital, which is the secondary healthcare level, and then we have the primary hospital, the health centers and health posters, and they make up the primary health care level. And under this, the health, like we have 5 health posters connected to 1 health center. And at the healthcare post are working community, they call them health extension workers. So health extension workers, each health post has 2 health extension workers working in those specific health posters, and 5 health posters are connected to 1 health center, and the health centers serve around like minimum of 25,000 people. While the integration seems to be like the structure is good, but there is no like proper integration. And like the health, if you see the health posters, very few, like less than 30% of health posters are connected to like a all-weather working road. So referral system is just very complicated. And shortage of providers is also the other problem. And if you see the health center is staffed by 1 midwife and 1 health officer. It might be updated, but the recent information I have is 1 midwife and 1 health center, 1 health officer works, and then other supportive staffs, like they have labs and pharmacy and everything. And they don't do like C-sections and everything. The primary hospitals do the C-sections, and the health center is just, sometimes they do vacuum. And, but if they are like in a very short distance to the hospitals, then the health officers they're like the physician assistants here. So they are a little bit higher than, with their skills, they are a little bit higher than midwives. So like if a midwife has some difficulty in like the normal childbirth, then should call the health officer, and then the health officer might do like, for example, vacuum aspiration or something like that. And in rural areas, midwives are trained to to do vacuum assisted births too. So specific aims of this project, the first thing that I was hoping to do was reviewing the magnitude and cause of maternal mortality, and reviewing and evaluating implemented strategies, and also identify gaps, and exploring available solutions implemented in other countries to reduce maternal mortality, and using that finding to make recommendations in Ethiopia, and generally making recommendations on identified gaps that I found. And methods, I did a systematic review, and I searched databases like PubMed and Google Scholar, and I've also used some gray literature. My inclusion criteria were all studies that were conducted in Ethiopia were included if they were conducted after 2003, and publications reporting interventions were included in the study. They also studies that were peer-reviewed, and quantitative studies were included. My primary outcome was maternal mortality, and my secondary outcomes were antenatal care, skilled birth attendant, institutional delivery, and postnatal care, or indicators of maternal mortality. I mean, maternal health. So this is kind of like I don't know if it's blurry, of how I did the search. So my original search from different databases had 551 studies included, and then after removing duplicates and going through initial title searches and reading abstract, and then I did reading full papers, and then I ended up with about 6 studies that were finally accepted in my search. And then I went with the result writing and analyzing the information that I got from the 6 papers. So my results included, I identified 3 strategies for reducing maternal mortality that were implemented in Ethiopia: the health extension program, use of maternity waiting homes, and deploying trained nurses to rural areas to increase skilled birth attendance. And all 6 studies revolved around this. 3 studies were about health extension program, and 2 studies about the use of maternity waiting homes, and the last talked about increasing the skilled birth attendance. So summary of the findings. So I said, as 3 studies talked about the health extension program. So as I said earlier, the health extension program was introduced in 2003 in Ethiopia, and with the aim of increasing access to the population in general. It's not only specific to reducing maternal mortality. Their training has like about 16 packages that ranges from like hygiene to maternal health. So in maternal health, their role included like advocating health education and health promotion about family planning and antenatal care. They provide antenatal care in the rural community. So they go to like different householders and they identify pregnant women and they encourage them to have like antenatal care follow-up. And then they provide that antenatal care follow-up by inviting those women to the health posts they work at. So they are expected to attend like 75% of their work is outreach. So they go into the communities and then try to identify those women and they encourage them to be involved in this care in general. So my finding about the health extension program, two studies evaluated the impact of the health extension workers on maternal mortality. And in this study, more than 8,000 women were included. And so they found that women who were visited by health extension workers had an improved antenatal care and postnatal care attendance. So more than 80% of women who were visited by health extension workers at least once, they attended antenatal care at least once. And about 57% of them attended at least 4 times. But they didn't find any impact on skilled birth attendance. And interestingly, of all the women who had antenatal care, more than 70% of them gave birth at home. And the third study was, it talked about, they tried to compare Ethiopia's maternal mortality reduction, the trend of maternal mortality reduction to other 42 countries. And they found that the 20% reduction in maternal mortality between 2016 and 2018 was attributed to the implementation of health extension workers. So that was their finding. When we come to the use of maternity waiting homes, one study talked about that, and they didn't see any impact on the rate of skilled birth attendance or institutional delivery. So this study was a randomized controlled trial, and what they did was they upgraded the maternity waiting homes. So they increased the supplies of the maternity waiting homes, and they compared it to the normal regular women who were getting their care from the health extension workers compared to the women who were getting their care from those staying in the upgraded maternity waiting homes. And they didn't find any change in the institutional delivery or in the rate of skilled birth attendance. And the third strategy identified was deploying trained nurses to rural areas of Ethiopia. This study was also a randomized controlled trials. They trained like nurses who graduated for 4 years, for 4 months on emergency obstetric care, and then they deployed them to the community. And then they did, and the nurses, they educate women, they tried to they provide postnatal care, and the system that they wanted to test was like a perfect type of care. So what they did is they trained these nurses in emergency obstetric care, and they had proper referral system set up if complications were to happen. And these nurses provided care for 9 months, and they assessed their outcome after 9 months of the implementation of this strategy. And after implementation, skilled birth attendance increased by 80%. And the overall rate of home births decreased. However, skilled birth attendance for home births showed an increase. And the interesting thing about this intervention is they could try to convince women to give birth in healthcare facility. And if the woman for any reason declined to go to the hospital, health centers and health posts, mostly if they decline, then they attend the births at home, which is kind of an ideal situation if it was implemented like nationwide. But so the rate of skilled birth attendance at home increased after implementation of this strategy. So after getting this discussion, I tried to see what evidence is available behind each of the implementations, and what evidence do we have behind these strategies that were implemented. The first thing I identified was just the challenges of maternal mortality reporting worldwide, but specifically in Ethiopia. And I did this because of the report that was done on the health extension program, claiming that the 23% reduction in maternal mortality came from the implementation of the health extension workers, or they are the community health workers. And I have seen that, first of all, we don't have like any evidence that increased antenatal care, increased skilled birth attendance, institutional delivery does increase it decreases maternal mortality. We don't have that evidence at all, but they are recommended by these international organizations. And the high income countries, majority of the births happen in healthcare institutions, and the maternal mortality rate is lower than the low income countries. So maybe there is something related. But I have seen like over or under reporting of maternal mortality in Ethiopia. And between 1990 and 2015, with the expectation of the meeting the Millennium Development Goal, and then the Sustainable Development Goal that was following the Millennium Development Goal, there was like this unrealistic expectation that was set for the low-income countries to meet. So with the resources available, with the broken healthcare system that was already set, it was like so hard for these low-income countries to reduce their maternal mortality by 70%. We have lots of studies talking about how this unrealistic expectation had put some pressure on these countries, and especially this impact was seen by like trying to lower their number, reporting their number, and then trying to be visible as those successful countries reducing their maternal mortality, because like funds and the financial support and the resources come through the implementations of these newer strategies, like the community health worker. They advocacy for use of community health workers started with like the 1 million community health workers for low-income countries initiation that was recommended by the World Health Organization, and there is support, financial support that comes with it. So countries have tried to get their way by reporting their numbers like lower. And then there is political impact when we come to like Ethiopia too, that was like pushing healthcare providers to report lower their number when they are reporting. Also accountability issues, because now people are being aware that they don't accept when mothers are dying. There is something wrong, because majority of the births are normal, no complications happen, but then this woman dies and people are asking why. So they try to go away from that accountability by kind of distorting the causes of maternal mortality, but also lowering of their number. And the studies have said that there is no change in the past 30 years in Ethiopia in maternal mortality reporting. And it's just playing with numbers, but there is no actual change happening. So when we see all these inconsistencies, it's very hard to conclude that the maternal mortality reduction that was reported in Ethiopia is due to health extension program. And I will come to the health extension program issues Next. And when I see the impact of maternal mortality reduction, especially for the health extension workers, and I already said this, like, we don't have any evidence, and I have identified like concerns about the knowledge and competence of the health extension workers by themselves. They are trained for 1 year, and they are trained about like 16 different packages. So the maternal health component is just one. And it's very hard to have like quality care when they are expected to do all these 16 packages and are expected to report on that. And there are some evidence that the health extension worker program have improved like family planning uptake. And there is some evidence that they have an impact on increasing antenatal care, but also in those two studies that I have reviewed, women who are like better socioeconomic status also had good antenatal care attendance. So we don't know if it was like their better socioeconomic status or the health extension program that improved their maternal health. And there are like bunch of concerns about the quality of care and their knowledge that was reported. And there are systemic problems also, like politics and the resources they have. And ICM recommends that like you have to work in an enabling environment to have like an impact. And they are not working, even with their limited capacity and limited knowledge, they are not working in enabling environment to have like a better impact on maternal health in general. And when we come to use of maternity waiting homes, Ethiopia, like they have been using maternity waiting homes for like in starting way early in 1980s, and previously they were in hospitals, and then almost all health centers have maternity waiting homes. And for these maternity waiting homes, for them to be like to have the effect that we are expecting them to have, they have to have like this structured connection between the community, the maternity waiting homes, and in the healthcare system. And they need like clear guidance in admission to maternity waiting homes. The concept is to include them, to have the women who are either far from the healthcare facility or who have like high risk pregnancies, as they define it, for them to stay. But for once, majority, like all women are responsible for their families, and they don't want to leave the family to live in maternity waiting homes for long and give birth. So they choose not to go. And other studies who have compared like use of maternity waiting homes. So in this study, they tried to upgrade the maternity waiting homes, and then they tried to see if the effect of the maternity waiting homes on skilled birth attendance. Another study that included like that implemented the same upgrading of the maternity waiting homes, but they had skilled birth attendants in place to check on the woman continuously and to assess the outcome. And they had like better outcomes on skilled birth attendance compared to the Ethiopia study, which is kind of was interesting and like an evidence for like if you have emergency obstetric care access, if you have skilled birth attendance, then maybe the outcome might be different. And increasing skilled birth attendance, I kind of tried to talk about it earlier. It was unique. This implementation was unique because it's like an ideal situation. If we had it, it would be like perfect to give women the choice of like place of birth. So they have access to skilled birth attendants, but they can give birth wherever they want. And respectful maternity care was also observed in this. So the women were, they were treated respectfully, and they had a say in their care, which was important. And it was also, this study was also like a good thing for indicating like a systems, we need a systems change. And the integration part is always, it comes priority. And having competent skilled birth attendants is also another thing. And integration of traditional birth attendants into the system, which is like a very huge topic. So on conclusion, we don't have any framework that is like 100% effective to reduce maternal mortality. There is, I haven't found any like causal relationship between the implementations that were, the strategies that were implemented and the maternal mortality, and impact of the health extension workers is not clear, and we need more research for like what we're recommending. So I tried to like shorten the recommendation part, but generally reviewing the health extension program is important, and establishing a maternal mortality review committee for the inconsistencies that are happening in the maternal mortality registration system, and training local midwives who are interested. And this is about like the, again, another complicated thing, but women, like students are forced to, not forced, you are assigned to different departments. So I was assigned to the midwifery department, which I had no idea about, that I cried about it. Like, I'm like, I don't want to be in this department. And it was my father who's like try it for just one semester and then see if you like it. And then I was lucky enough to stay in this profession for long. But other midwives, there are like lots of midwives who don't feel the same way as I do. So if we train like local midwives who are just students who are interested, anyone who is interested in becoming a midwife, and then supporting them with resources and integrating the system to have like a good, proper way of emergency management, and then making providers accountable. And this specifically is for like the obstetric violence. It's just so sad how especially rural women are treated in the settings, and it's all connected. Like if you don't want to be a midwife, then you take all your like unhappy life on those women, and it's just a very complicated situation. So and implementing strategies that are based on the local needs than just like a general recommendation. Strengths and limitation. So like just evaluating the studies. This is, I believe, is the first study evaluating what has been done, and the methodology I used, like it was so important for me to have like this like clear expectation, which can be like I didn't have to be like all over the place. I have this inclusion criteria, exclusion criteria, and then I followed those, and I ended up here. So having that was like the strengths of this study, and it could be a basis for other future studies. I have identified like so many problems in my literature review, which can be like, which so many projects can come out of that. And for limitations, I didn't have any other like reviewer as recommended, but I didn't do any appraisal of the studies that I had chosen, and use of limited number of research databases because of time constraints. And recommendations for research. We need more research on the effectiveness of skilled birth attendance. We need more research on the evaluations. I mean, how we evaluate research implementations and strategies implemented, and also on home births and inclusion of traditional birth attendants. These were some of my references. I think I went over time. Have any question? Yes.
I have a question for you. Could you go back to that first list of recommendations, that slide? Not that one, but yeah, going back a little more.
Yeah.
That one. So like reading each one of these is like a punch in the face, right? I mean, they're huge. They are massive recommendations, and every single one of them is just like, yes, 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 right? You just, so given that and the frustration of not having the solid research to say that this works, do more of this, how do you feel like with limited resources and everything that you've learned through this project, what would you say is probably the most impactful strategy that could be implemented to reduce maternal mortality in Ethiopia?
Like, what I think is, we're not like, what do those women need would be like the next question I would be asking, like, what do our community need? What do the communities, the women in the rural areas of Ethiopia need? And of all the births that are happening in Ethiopia in general, more than 50% of the births are still happening at home. Why? Because the women are choosing. They don't want to go to the hospitals, even though they have access for some places. For others, they don't. So what do they need? And just listening to women is very important. And then we can start from there, and then we can like do something about it, is my first intake. Because like the national recommendations are not working, because they don't know our culture, and they don't know like what is more important to us, just as a separate community than others. So we can start like from within, and then we can start using our resources, what we already have. And like traditional birth attendants, women are choosing traditional birth attendants because they feel safe with them, even though we are pushing them out, and even though we are replacing them with, again, we thought the traditional birth attendants are not competent, and then we are replacing them with other trained kind of incompetent people, and nothing is changing. So yeah, I think it's just we starting from the community would guide us to like the better strategy to implement. That's what I think.
I just want to piggyback off of what you were mentioning now about the traditional birth attendants, because you mentioned that when you first set out to do this project, you wanted to focus on the traditional birth attendants, and you wanted to highlight their scope of practice and their practices to show their value to the system.
Mm-hmm.
My curiosity right now is if after conducting this literature review, that focus changed. So the question is, what is it about traditional birth attendants that you would focus on researching now after you did the literature review?
I would be curious to know, like this curiosity came after me starting to attend like births at home. So home birth was not an option for me in Ethiopia. And when I was in a second year student, doing midwifery program, we were instructed to train traditional birth attendants about hygiene, hand washing, and using glove. And then I remember their faces. They were like, they collected them from the community and they brought them to the teaching hospital. And then they were sitting like on the corridor, frightened, scared faces, observing like women screaming all over the place. And they were scared of the environment. So that was the training of traditional birth attendant that started in the early 1990s. And they said it didn't change. It doesn't have any effect on maternal mortality. Mm-hmm. So, and we were teaching them to like how they wash their hands, and hepatitis B was kind of like the epidemic at that time, and the intention was to prevent that. And I came here and started doing like home births, and like I had like that my first attitude with traditional birth attendants. I was born at home, and the midwife that helped my mom is still alive, and she talks about her like what she did and how she gave her a buzz when she was in labor, and like she's happy talking about her. There was no like sadness in my mother's face. And after doing this, attending births at home, then people can do this, like women can have their babies at home. And like I want to know what they do. Like we are trying to, like we label things, right? We label things, we name things in the healthcare. We call it antenatal care. And they don't know what antenatal care is, but they've been doing this for a long time. And they've been attending births, but we have like some new terminologies for it. And those midwives, they don't know anything. They are midwives. Like we're labeling them as traditional birth attendants and kind of taking away their knowledge and the respect they have in the community. And then we are replacing them with us trained midwives using different terminologies. And so I want to know how they practice, how they do antenatal care, and how they do assist births. And I asked one of the traditional birth attendants at the time, what do you do when like you have a retained placenta? And then she's been telling me like, I do these types of massages, and I use that she didn't mention the name of this leaf, and I would give this to the woman, and then the placenta comes out. And so that's what we do, but we call it like different thing in our book. So after like knowing these things, then I would see how can they be integrated into the system, and how can women still get like respectful care that they deserve from the people they like respect and love. Yeah, that's what I think.
Thank you. So are you saying that like you think like the most effective thing would be to provide funding for like the community midwives to provide services there? Like, I think that would be the most impactful thing.
Yeah, if that's what the community needs, then we should go for it.
Yeah.
Is what I think.
Yeah.
Thanks. I'm just so excited about this project, and if I could share with the group that actually for the management class, she actually created a fantastic health promotion plan to do just this. So she did all the mechanics. We just need to find a funder. Yeah, exactly what, yeah. So we just need to find a funder. She's got her budgets, she's got everything. So I want to go back to a point you made, which I think you touched on even in your answer with Dr. Gordon. So you mentioned an early slide that a lot of the solutions are coming from the global north, right? Based on research done in the US or done in high-income countries. And then that's what any international funding that's the criteria they're using, and then kind of like mashing these projects, you know, into countries with a different context. Did you find anything around, is this beginning to change? Like, as we have, you know, more research coming out of Ethiopia, more research coming out of the global south, are funding priorities beginning to change? Are, you know, are you seeing that? Any evidence of that?
I don't have like a current evidence for that. Still, like the health extension program is, for example, they are still doing it, and they are training, like we have around 40,000 health extension workers now, and they continue to train more health extension workers where people are already like, we don't need more. And the health extension workers are also, they are kind of demotivated because they don't have like any next career path that is planned for them. And it's already like, it's stuck everywhere. If you think about the training of, like, there are some international organizations who are focusing on like improving skills of midwives, for example, and then they try to train them in emergency obstetric care, but you don't see a systems change. Like we are training, they call it like capacity building, and then they try to do different things in different areas, but as long as the system is not changing, it's just so hard to have like impactful change. So maybe there are, I'm not aware of like the current changes that are happening because I'm away.
Yeah.
So yeah.
Wow. Great work, Tigist.
Thank you.
Like getting to another PhD project.
Yeah.
Very good, very good.
Thank you.
Yeah, I have your poster and yours too. All right.
Yeah.
Well, everyone, you can sit for now a minute, Tigist, and we are going to take a lunch break. So we will be back here at 1 o'clock sharp for our final 2 presentations. We hope you all will come back and join us, and that you all will eat and all of that. So thanks so much for being here, and we'll see you soon.
Great job, Kristen.
Did you say I know the cafeteria isn't open, but there's a vending machine?
Yes, I want to mute us here. I'm still having trouble with this situation, so I'm so sorry. I'm going to mute this and then I'll talk to you about food option stuff. If anyone could help me figure that out, it would be amazing. Stop share, that'd be good if I could figure out how to do that.
Gotta go that direction
Can I have you
with your
do it? I'm
mouse.
so
Yep.
sorry.
No, it's all good.
So for food